everyone. Welcome and thank you for joining us for today's session, Frequently Asked Questions on Multiple Myeloma Following Relapse After 1 to 3 Prior Lines of Therapy. I'm Mary DeRome, Senior Director of Medical Communications and Education at the Multiple Myeloma Research Foundation. Today, I'm joined by Dr. Andrew Yee and Ms. Stephanie Sanford from the Massachusetts General Hospital in Boston, Massachusetts, and John Selin, a patient from Georgetown, Massachusetts. We've invited them here today to answer some of the frequently asked questions we received from patients and caregivers about early relapse from treatment. So Dr. Yee, I'm going to start with you. Again, thank you for being here with us today. So can you tell us, how do you know if a patient has relapsed from their treatment? I think many patients get confused as to whether is it a lab test, or is it a symptom that they begin to feel, or is it something else?
Right. Thank you, Mary. And thanks again to the MMRF for hosting this question and answer session. And thanks to John for graciously volunteering his time to answer questions, and to Stephanie, who we work closely together. So again, I want to start off by saying thank you. But the question that Mary had, I think that's a core question that emerges since. When I think about myeloma therapy, I think about how, in the beginning, there's a lot of, when patients are first diagnosed with myeloma, there's a lot of drama, for lack of a better term, like getting the diagnosis. And you have to, I think a lot of patients I meet, they may have just retired. They're thinking about what they're going to do, and because myeloma is a diagnosis typically of people kind of around the age of retirement, and then they get told that, they get told about this new cancer diagnosis, and then it kind of turns their life upside down. And to meet all these new people and the treatment, and you have to learn this whole new vocabulary and meet all these new people, and it's a big imposition on their life, with lots of visits. But then, once you get over that hump, for most patients, they sort of, they get to a stride, so to speak. They kind of, after the warm-up period, they get into their stride, where for the majority of patients, you put in a lot of work in that initial course of therapy. There's a lot of work that gets put into it, but for the majority of patients, you get the dividends back in terms of feeling better, and you get the immediate gratification from looking at the labs, and you see the labs looking better. And it looks great. So there's a lot of work you put into it, lots of visits, dealing with side effects, navigating through all of that. Now, the majority of patients, the initial therapy works well for months to years, many years for the majority of patients. And you get to a point where you kind of hit the stride, and you're on, for the majority of patients after initial course of therapy, they're on maintenance therapy, where the disease is in check and they're on a pretty stable regimen, and people are thinking about, moving on with their lives and their next steps. And, the myeloma, and we talk about this, how it goes from being on the front burner to, for many people, you can just put on the back burner. You kind of think about it intermittently, but hopefully for the majority of people, it's not front and center all the time, like it was when you first get the diagnosis. So now, the thing about myeloma is that, whenever I see a patient, it's not curable, but it's very treatable. But because it's not curable, the disease does tend to show up again over time. For many people, I think we can put into remission where it's under control, it's not active. And I kind of think of it being in hibernation, like the disease is in hibernation. But over time, sometimes the disease can come out of hibernation. And that would be what I think about as a relapse. And I think we might be touching upon this later, but maybe this would be a good time to talk about, how does relapse defined? So typically, when I see a patient, I always ask them how they're doing, how are things going on the therapy, just to make sure, because side effects can emerge on treatment. But we also do like routine laboratory studies to check on the status of their disease. So the routine laboratory studies, typically when Stephanie and I see a patient, and John can acknowledge it too, because he knows he gets lots of tubes drawn every time. It's part of It's like asking the pizza man what's for dinner, right? So we always check like kind of the myeloma related labs, which include checking, the serum protein electrophoresis, as well as the serum free light chains to monitor the disease. And for most patients, those numbers are pretty flat, they're stable. But an indication of relapse can be when the numbers start to increase. And then if the numbers are starting to increase, then we start to think, okay, maybe the disease is more active as the disease is coming out of hibernation. And you can tell that because the numbers are starting to increase. Now, just as an aside, it also depends on if a patient's participating in a clinical trial or not, because it turns out for relapse, there can be more formalized definitions of relapse in terms of the actual magnitude of the increase. Because some patients, you can have a small, very gradual increase in the monoclonal protein that may or may not be clinically important or something to act on. Maybe in some cases you can just watch very closely. But for purposes of a clinical trial, for example, the monoclonal protein increases by 0.5 gram per deciliter from the best response, that could be considered evidence of a relapse. Or if the free light chain increases by 100 milligrams per liter in patients who don't have measurable serum protein electrophoresis. So that would be another example. But that would be kind of a clinical relapse where a patient, for the most part is feeling well, but then you detect the relapse mainly just based on these monoclonal protein or the serum free light chain number. So that would be how I define a biochemical relapse. So most patients, I say, because we check, because we have these frequent visits just to see how they're doing. For most patients, we can see that based on just on the laboratory studies alone. Now, you want me to keep talking, Mary? Because I can keep talking. Or maybe I'll pause it.
So I did want to ask, so it seems like what you're saying is that some patients do have what you might consider to be a more rapid increase in that marker. You're talking about M protein or their light chains, but some patients sort of have their numbers creep up a little bit. And so the rapid increase is more concerning than kind of the creep.
Yes, exactly. I think the magnitude of that, that's important. And then there can be a little bit of a gestalt to it as well. I mean, sometimes there's a formalized definition, and sometimes it can be more of a gestalt. And it gets to how, this is sort of a corny joke, but people, multiple myeloma is kind of multiple in the sense that there are multiple types of myeloma in terms of their clinical presentations when you first meet patients. Some patients, when you first meet them, their myeloma is defined because they have a bony lesion, or they have kidney trouble, or they have mainly low blood counts. Mm-hmm. And the way they present, the variability and the heterogeneity in how they present can also materialize in how the disease were to show up again. They can be pretty heterogeneous as well. And you can really see a divergence in how what the disease looks like at that time.
Sure. Okay, great. Okay, so Stephanie, so we're talking about monitoring patients when they come in for their regularly scheduled appointments. I mean, so how often are patients monitored? And there's tests like blood tests, urine tests, imaging tests. So to ensure that a patient either stays in remission or to detect any possible relapse, how often are these patients monitored?
Great question, Mary. And I also want to echo Andrew's thank you to the Multiple Myeloma Research Foundation and especially to John for joining us today. So thank you. Myeloma is, I'm thankful in myeloma that it's easier than some other diseases to monitor because we can see what's going on, most of the time in the blood. So, typically it can vary across different practices, but typically the way I practice is, and Dr. Yee along with me, we see people about once a month, and that way we can check in on, mm-hmm. clinically how they're doing, mm-hmm. how they're feeling. But even sometimes a more important or as important part of that visit is getting those labs, mostly blood, drawn. In order to see, are things stable? And sometimes those visits are really quick when the labs look stable and everyone looks good. Mm-hmm. It's like, great, our check-in's fine. Mm-hmm. And so we're able to see a lot and monitor so many patients very easily in the blood. Our cadence, while people are on active therapy, really no matter what line of therapy it is, if it's relapse or initial, they're on active therapy. I'm going to see a patient at least once a month, sometimes twice a month. But those lab markers we're going to draw once a month. I'm not sure it's clinically indicated to draw them more often than that. Once people get off active therapy and onto more of a maintenance therapy where we know the disease, at least at some point, has been under control, once we get a few months out from that, we can pull back a little bit. And it might be, their genetics that they initially presented with. If they have anything else going on, we can pull back to every 6 weeks, 8 weeks. I think rarely, but we do pull back to every 12 weeks sometimes if people are really stable, or if other things are going on in their life that they're dealing with a knee replacement surgery or something like that, and we can put the myeloma on the back burner so they can manage some of these other things. Imaging is another question that comes up frequently, because we can see so much in the blood with just a little, needle prick. We often don't do a lot of serial imaging, and we kind of try not to. At times of relapse, oftentimes, part of that workup will be initially imaging. But if a patient's showing, clinical improvement on treatment, they're not having any side effects or pain or issues anywhere else, oftentimes we won't do a lot of serial imaging. If disease is under control, or maybe not in a full remission but close, we might not. However, we do have a very low threshold to do any imaging should any clinical issues arise. So, a shoulder that's had arthritis for 5 years, but just all of a sudden changes a little bit, I'm going to get imaging right away, but not really just serial kind of for just to monitor.
Right.
Urine studies also can be, they can sometimes be helpful, but I'm not going to make clinical decisions just based on urine studies by themselves. So a lot of times there are some patients with some kidney disorders or kidney issues that we might watch and interpret that along with all of the other things that are going on. But I think the urine results and the urine testing is becoming a little less and less important over time.
Yeah, that is sort of what I've been hearing as well. So it does sound like once patients have achieved maintenance and they're on maintenance and they're stable, then they might be coming in to see you less frequently based on their stability. But that may not be the case when they're on initial therapy, or maybe after they relapse, they have to go on a new therapy. So then you would have to see them more frequently because of those things. So that makes sense. So John, I'm going to go to you now. Can you tell us how you found out that you had relapsed from your treatment? And can you tell in any way that you had relapsed without seeing the lab test results? So did you feel like you relapsed, or was it a surprise to you?
Both ways. And, since it's been 18 years since my original diagnosis, I've been on 4 lines of therapy, sort of, so to speak, and I've had 3 relapses over the years. And the last 5 years, I've been with Dr. Yee and Stephanie. They've been a great team, helping me out, getting me into a good position. But my original line of therapy 18 years ago was a autologous stem cell transplant. And then I went on, and that worked out very well. And the maintenance at the time, now this is a long time ago, 18 years ago, maintenance was just bone strengthener infusions, and that was going for 8 years. And things, I'd be monitored with lab tests, not every month, maybe I think it was going to be like every 3 months and something like that. But all of a sudden the IgG levels in the blood test were going up. At that time, they weren't really monitoring light chains. Every once in a while they got tested, but not on a regular basis. So it was the IgG levels was rising. So that was the first relapse. And then 4 years, so that was 8 years after the original transplant. Then 4 years after that relapse, I was on Revlimid, and there all of a sudden I was starting to get pains in my side. I thought I'd bruised my ribs. You push on the ribs and it hurt. And the primary care doctor did an X-ray and said, "Gee, it looks a little funny," and contacted, and it was sent to my oncologist at the time, and immediately did an MRI, and they could see that I had lesions growing on the outside of my spine bones. So it was, I think the term was extramedullary type of lesions.
Mhm.
And so that was treated. And so that at that point, then it was 2 years later. So I had treatment. And then 2 years later, I had shoulder pain. All of a sudden, the shoulder was real hurting every time I moved and so forth. And there, again, X-ray and MRI showed that the primary problem was that I had broken my clavicle. But the MRI and so forth, they showed lots of lesions in that scapula area. And so then and at the time I was with Dr. Yi and Stephanie. And so we went into the line of treatment that I'm on right now, and it's working very well.
Good. So you did feel it. So it maybe it hadn't come as such a shock to you because you kind of thought maybe something was going on, right?
Right. And the blood tests were starting to, and in each case they were showing some rise. So there was confirmation. Let's put it that way.
That makes sense. Okay, so Dr. Yi, on the webinar that we had a few weeks ago on this same topic, we heard something about biochemical relapse and clinical relapse. So can you help explain the difference between those two types of relapse? And can you define some other terms that patients often hear, such as early relapse or aggressive relapse? And does a patient's cytogenetic profile, meaning what's happening with their chromosomes, translocations, and deletions, do those things factor into these definitions?
Right. Thanks, Mary. So John's case, so I think John's case is really remarkable because I think, John, 18 years, he's really seen the art, the whole of the really amazing developments in myeloma therapy, and he's really benefited from that as we're speaking. And John's case also demonstrates the difference between the biochemical as well as the clinical relapse. So in John's case, when he first, he mentioned he had the rising IgG, though it was mainly laboratory-based tests, and that is the biochemical relapse. But when he had the rib pain and the rib issues or the spine issues, then that I think is more as the clinical relapse, where the patient where you can see the myeloma actually causing symptoms or some clinical evidence of disease besides the monoclonal protein studies of the light chains. So when I think of clinical relapse, I think of, the bone lesions, or, patients can have new anemia or thrombocytopenia that's out of proportion to what was going on before, or somebody was developed, kidney problems related to the disease. So that would be more clinical relapse. And as a side note, I think the majority of the time, the clinical relapse is generally associated with, evidence of the laboratory parameters usually reflect that. So majority of the time, patients have a clinical relapse, you can see evidence of that in terms of the rise of monoclonal protein or rise in light chains. But a couple of points to emphasize would be, I think that's why when you see us, we pay more, for us, we're more sensitive if their rib hurts or their back hurts, we try to be more, our ears do perk up a little more.
Yeah.
It can be really complicated because a lot of people have back pain just, as people get older, you have older spines and people have back pain, et cetera. But I always do wonder, does that relate to myeloma or not? And that's why I think our threshold for ordering a CAT scan or a myeloma is a lot less to confirm is that the case or not. Now, very rarely you can have patients have disease progression with new bone lesions without a change in the monoclonal protein. That can happen, but that's less frequent. And sometimes people talk about non-secretory. Their relapse can be non-secretory, as in you don't see the myeloma making. So that can happen later on as the disease evolves, but that's not, I'd say it's probably under 5 or 10% of cases. Then your next, and that relates to kind of the frequency of the imaging. So for patients who have a non-secretory relapse, those patients that do monitor with imaging more frequently. But as Stephanie was saying, typically we don't necessarily monitor patients routinely with imaging. But I think something else to appreciate, there's a lot of heterogeneity in practice. So I acknowledge that lots of, there's not really one right answer here in the same way that there's not a right answer. It's not one size fits all. Now, in terms of the early versus late, early relapse, that it's sort of early relapse implies like disease that relapses in a shorter time frame than average. So, when you think about initial therapy in myeloma, generally speaking, on average, people have a runway of about 4 to 5 to 6 years on average from the initial therapy. So something less than that could be considered, and that happens because it's the average. That could be considered an early relapse, but for the purposes of some of the clinical trials, sometimes people think about within like a year of autologous stem cell transplant or within a year and a half of autologous. That could be one, definition that's being used by clinical trials, because there are clinical trials looking for patients who have a so-called early relapse. Now, Mary, you brought up the question about the FISH and the cytogenetics. And people talk about, FISH refers to the fluorescence in situ hybridization to cytogenetics. They refer to how the chromosomes, they refer to under the hood of the myeloma cell. How are the chromosomes attached to each other? And the chromosomes are sort of the instructions, the instructions that tell the cells how to divide. And there can be some configurations that sort of where the instructions are not, they sort of short circuit, right? So it's sort of like if you have a book and you miss, it's kind of rearranged and the instructions get scrambled. It can short circuit how the cells are supposed to behave. And there's certain chromosomal abnormalities that can be detected by fluorescence in situ hybridization, or FISH, that can be associated with, duration of response may not be as long as the average patient. So there are some that the classic ones we think about are translocation 414, 1416, deletion 17p, where part of chromosome 17 is missing. And this refers to in the myeloma cell. It's not something that you're born with. Okay? It's something that the myeloma cells acquire as part of becoming a myeloma cell. Recently, we also appreciate like gain or amplification in 1Q. So we are starting to pay more attention to these, and that this can influence in terms of your, the type of initial therapy, as well as, the maintenance regimen. And sometimes it provides some thinking in terms of, if you see that with a relapse, you might think about choosing one therapy versus another therapy. But again, this is really a moving target. Now, I should also say, as one more side, there are also patients who can have an earlier relapse and still have normal cytogenetics as well. So it's not, you can, I think Stephanie and I, we definitely have plenty of patients who do not have high risk FISH and who, disease the duration of response does not last as long as we would like.
Interesting. So speaking of relapse, Stephanie, I mean, pretty much every myeloma patient is going to relapse, right? So, and how many patients, how many times do patients relapse? I imagine if you're one of these people who has not a very long duration of response to a treatment that you're on, that you may relapse more frequently from subsequent treatments, right?
Yeah, it's a really tricky question given the variety of patients that we have and the variety of ways people present. So, with sometimes the initial treatment, the remission from that lasting up to 5 years, this is a disease largely of an older population. So if someone's coming in 85, 90 years old and they get a great first remission, they might not relapse. They might have other health problems that come up in the future while the myeloma is on the back burner. So that can almost kind of be best case scenario where you get these long remissions. And again, by the time, if you're 80 and then 10 years later something happens, you're 90. So the myeloma isn't the biggest deal. there is that other side, that some of the tougher, kind of more aggressive diseases that Dr. Yu was describing again, which, sometimes we can predict based on how they present or how, genetic changes. Sometimes we can't predict, where people can relapse more quickly, multiple times. It can take, a few tries to get them into remission, as opposed to responding right to that first therapy. Like we're kind of getting used to expecting that, because we are often able to see that now. There's no number of times somebody can relapse. And sometimes, as the relapses go on, these remissions sometimes get shorter with each time. And so we do have patients who kind of go from active treatment to active treatment and don't have that long, any or a long time of remission in between. Thankfully for that population, and I think moving forward, for even people who have long remissions, we're finding new treatments all the time. Every day, new things are coming out. So we're able to keep switching therapies and having so many more options than we did, when John started this, so many years ago.
Things have changed a lot since then, that's for sure.
Yeah, and 3 lines of therapy. I have some patients going through 3 lines of therapy in a year or two, and here we are 18 years, and in that 18 years, there have been, 20 other lines of therapy that have been created. So we're in a much better place overall, but there can really still be a tough spot when you're finding that frequent relapse.
Sure. So, John, when you mentioned that you've had 4 relapses, right?
Three lapses, four lines of therapy.
4 lines of therapy. Okay, sorry, my mistake.
The fourth one is still going well.
Okay, I'm not trying to jinx you. So while you were, when you relapsed and then you went on to another line of therapy, did you have any expectations about how long your response to that next line may have worked? And do you really very carefully follow the lab results that you get whenever you stop in to see your care team?
Yeah, the answer to that last one, yes. The lab results, as soon as they come up, I get notified on Patient Gateway, and I take a look at them as they come in. And but in terms of expectations, certainly after the initial treatment, after the transplant and 8 years in remission, it was sort of like, I don't have to worry about the myeloma. I knew it wouldn't be cured, but it was sort of like I don't have to worry about it anymore. So when things started rising again, the IgG levels, it was okay, it was sort of a shock, and said, okay, I guess I do have to worry about it. But I knew that there would be relapses, and talking with the doctors at the time, and also I would see the results. I would follow the results of the major hematology and the different conferences and the webinars where they summarize, and you see the trials, and you see that the times are, they're not 5 years, 8 years out. Of course, they don't have time to do the trials that long, but you see that patients do start to fall off as the line goes down, so that years are good expectations. My second line of therapy was 4 years, and before the relapse. But so I felt good that okay, I'm responding well. I've been very lucky, very fortunate that each of the lines of therapy, when we had to change, that responses were good.
Yeah.
And right now, the 4th line of therapy, it's been 3.5 years, and still going well.
Great. Keep our fingers crossed for you.
Yeah.
So Dr. Yi, here's a question. I actually have wondered about this myself. So since many patients are treated with multi-drug regimens, like patients are never given one thing at a time, or hardly ever, right? Especially these days, you're getting usually at least 3 drugs, sometimes 2, maybe sometimes 4. And if a patient who's on all of these drugs at one time and then they relapse, is there a way for you to be able to tell which of these drugs is no longer working? And would you then just like swap it out for a different drug in the same class, or just sort of move on to the next thing?
Right. So, that's a that's a question with some nuanced answers. I think so. Sometimes you really, if a patient's on a 3-drug regimen and the disease progresses, I think it can be challenging to know exactly which drug is no longer working, and sometimes you may never know. So
right.
I think a situation that might, I think there are different layers to this. So for example, if a patient, the typical case, so somebody who's on one line of therapy, they say they had initial treatment with lenalidomide, bortezomib, dexamethasone, and then the RVD, they had autologous stem cell transplant, and then they're on lenalidomide, like Revlimid maintenance, and then the patient's experiencing some kind of relapse. The question becomes, what choice of therapy do you do next? And now, in 2022, we have all these different options you can choose from. So some patients, I mean, my bias would be if the patient has not seen an anti-CD38 monoclonal antibody, that would be a good time to think about using an anti-CD38 monoclonal antibody. So your good choice could be daratumumab or isatuximab. And then you think about, and then we're talking about partnering these drugs to get maximal benefit. Sometimes you can think about combining it with pomalidomide or carfilzomib.
Mm-hmm.
And that's a common question. I think it really depends on the patient's situation, because the regimens are different. Ones, and the scheduling can be different, as well as the side effect profile can be different.
Sure.
I think if you progress on lenalidomide, the pomalidomide, even though it's the same drug class, still has activity. So in that case, the pomalidomide is still an option. And that carfilzomib is also a great drug to consider too, but it's a little bit different. It's IV, intravenous, and different side effect profile. Now, I wish I could say, I mean, the dexamethasone, is a lot of patients have a love-hate relationship with the dexamethasone. Some people love them, some people love it, some people hate it, some people have a conflicted relationship with it, kind of like most human relationships, right? That was supposed to be a joke. But the dexamethasone though is when you talk about like swapping out things, the dexamethasone is a pretty common thread throughout almost all myeloma regimens.
Sure.
And that's because the dexamethasone does accentuate the activity of the other partners. And then there are some patients where, in some patients, if the relapse is sort of a gradual relapse, not like an aggressive, maybe it's just the numbers are changing a little bit. Sometimes I have just used daratumumab by itself, actually, for those particular patients. And if a patient progresses on that, sometimes you can actually see activity with adding on a drug that they've had before, because there can be some synergy between, say, a CD38 antibody and, say, like, going back to, lenalidomide, pomalidomide, or a proteasome inhibitor. But I think that a lot of it can depend on the scenario in terms of the type of relapse and what the patient has seen before. But I can also see cases where, if somebody if somebody was, say, like on daratumumab, pomalidomide, dexamethasone, for example, and if that treatment is no longer work, I can see situations where you can replace all the components completely, where you would say do carfilzomib, say cyclophosphamide would be one example. I mean, there are all these variabilities you can do. So in some cases, a lot depends on the scenario. Some patients, if it's a gradual, maybe you could just swap out one of the drugs. But if it's something that needs more, you might swap out more.
Mm-hmm. Yeah, that makes sense. Okay, so now we're going to talk a little bit about treatment options for relapse patients who have had up to 3 lines of prior treatment. So first, Dr. Yee, there is still confusion about what constitutes a line of therapy, and we honestly get that question at every single webinar. What is a line of therapy, right? So for example, if the patient said that they've had RVD therapy followed by the stem cell transplant and then maintenance with Revlimid, and then they relapsed within a couple of years and now they're on a different triplet regimen. So how many lines of therapy has that patient had?
Right. So technically, if someone is on the initial therapy plus a transplant plus me, that's considered one line of therapy.
Mm-hmm.
So that and if you were to change out the treatment because of disease progression, then that becomes your next line of therapy. But I do agree that it can be confusing because they're on 3 different drugs
Right.
in the beginning. And sometimes, how we define, relapse is sort of, it gets tricky, right? Is it really important? Is it really the number of lines of therapy, or is it really the types of therapies that you've had? So I think there's increasingly an appreciation that it's also the types of therapies that you've had is important to, not just necessarily the numerical number of therapies.
Right. So it's really more of a class, sometimes more of a class issue.
Yeah,
You've had certain classes, right?
Right. So, so you've had a CD38 antibody there, so a lot of the clinical trials, when people report out results, they're talking about the so-called triple class exposed or refractory. So triple class exposed would be, having had an immunomodulatory drug like lenalidomide, a proteasome inhibitor like bortezomib or Velcade, and then the CD38 antibody like daratumumab or isatuximab. It gets also a little tricky too, because how the FDA, the labeling for, in terms of how these drugs, how the FDA, in terms of the approval for the drugs, talks about, is it lines of therapy or is it the actual, there can be a little bit of a gray zone in terms of how you define, in terms of the package insert and insurance. There can be some variation in interpretation. Whereas I think for clinical trials, when you read about a clinical trial, it tends to be pretty rigid,
right?
Pretty formalized, the definition for lines of therapy.
So, and sometimes patients are on a line of therapies. They're, taking 3 drugs, and they begin to have some side effects from one of the drugs, and then maybe there might be a dose reduction in that particular drug to really sort of help those side effects. But that wouldn't be considered a different line of therapy, or would it?
I think if somebody, if you had a dose reduction, that would not be considered a line of therapy. If you had a dose increase, that probably not. But suppose, if somebody was on RVD in the beginning, and then the Velcade was discontinued for neuropathy, and then changed, then you had to change to carfilzomib, for example. That would probably be considered a new line of therapy, but I might have to double check. If for toxicity, I might have to double check that. But that gets to also, I think, in terms of swapping out treatments, right? Sometimes, I definitely have patients where the initial therapy was, they had RVD, but then maybe the response wasn't, you're trying to get them ready for a transplant. You want a deeper response. So I've definitely had patients where, I've replaced the bortezomib with carfilzomib, and you definitely see these beautiful responses subsequently.
Yeah.
So sometimes it's helpful to change all the drugs, and sometimes it's not necessarily necessary to change all the drugs.
Yeah, that makes sense. I mean, it's different. Like you said, it's not one size fits all, and you sort of have to figure out what's going to work best for each patient. So sometimes by trial and error, right? You just don't
hopefully
know.
less error and less clinical trials, but no errors.
So, Stephanie, is a stem cell transplant a treatment option for patients at relapse, even if the patient has already had one? And what are the chances that a patient might not respond to a transplant at relapse?
This is a controversial topic. Transplant's real controversial, very controversial right now in myeloma. And just a little background on that is a lot of the clinical trials that have shown that transplant is a great option for myeloma patients were done before we had a lot of these new therapies that we're feeling confident are giving us long sustained responses with coming in, weekly or 3 weeks out of the month for treatment versus really interrupting your life for, month-long hospitalization, lots of appointments, 90 days after, 30 days after, and the concerns of, the mortality and morbidity just associated with the actual transplant itself. That being said, here's John as a great example of someone who had a transplant. Now that was right off the bat, not at relapse, but and did fantastic with it. So anytime we talk about transplant, we have to take some of those those that information into play. Transplant's always an option, almost always. So we just have to figure out where, in the line of therapy we want to put it, or if we want to put it there. I don't see a lot of second transplants being given. And I think that's, for the reasons we were talking about, we have all these other new promising drugs to try that aren't going to interfere and give quite the toxicity that the transplant would. But we still do have plenty of patients that we are giving transplants to. Some of the so we are still doing that, and we have a minority of patients that are going on to transplant right now. I wouldn't, sometimes the upfront transplant will give you a little bit more. Those studies are showing that might give you a longer remission starting up front. That being said, we don't know. So sometimes, when we do it a little later on, we get a great response as well. So we really use transplant almost just as another line of therapy and throw it all in there. And when we see how easy some of these newer lines of therapies are, a lot of people are opting for that, even if we put some of the decisions in the patient's hands and opting for that earlier on.
Yeah. So I know so some of the information from that trial, the determination trial, we've talked about that quite a bit on some of these events that we've had since ASCO. So it's quite an interesting topic. And I really think it's going to be really interesting to find out if they do a similar study with some of the newer regimens that we're doing, some of these 4-drug regimens that are really very effective in the upfront setting, that the results might be quite different. So, I mean, time will tell on that, I guess. So
you're asking Stephanie a lot of the hard questions.
Yeah.
Stephanie's getting the hard questions.
I'm going to tell you, Stephanie, Andrew paid me to do that. So, the hard ones. So let's go to John. John, what can you tell us about some of the treatments that you've been on? Like, what lines of therapy have you been on since you've been diagnosed a long, long time ago? What responses did you achieve, and what are some of the side effects that you've had from some of the therapies that you've been on?
Okay. As I've said, 18 years ago, initial treatments are completely different. Similar in some cases, but what was available was not the same. And initial treatment was with Thalabid, the precursor to Revlimid.
Yeah.
And on Dex, and also with Dex and bone strengtheners. But I also initially had radiation treatment for lesions in my back. I had kyphoplasty to shore up 3 of my vertebrae that were crushing. All this before in preparation for the transplant. But the side effects, I really had a lot of bone pain. It was really intense bone pain. So I was on a lot of pain medication, and the pain medication leads into side effects. So I was taking a lot of other medications to alleviate the side effects. So I was on a lot of stuff going on during that time. And the biggest problem during the initial treatment was the peripheral neuropathy in my feet and my fingertips. And that, due to the Thalabid, and so that sort of gave me an impetus to say, okay, the neuropathy is going to get worse probably over time. Let's do the autologous stem cell transplant. And so that was pushing that was the primary reason. Okay, we're going to do this transplant.
Well, I mean, at the time there really wasn't much else, right?
Exactly. Yeah.
We had no other options.
Right. And then as I said, that was good for about 8 years. And then the next line of treatment was the Revlimid, and that was for about 4 years. And then when that was in relapse, the next treatment was Velcade, and that by that time it was subcutaneous, and which supposedly there was less of a side effect or the neuropathy effect, instead of the infusion, and also was taking Revlimid with the Velcade, and then that relapsed, and then now I'm on a triplet, daratumumab, Dex, and also with Pomalyst.
Oh.
Actually, I've switched over to Pomalyst, I think, back with the Velcade also, when that was available. And, so for 3.5 years, it's been doing, I've been, feeling well, let's put it that way. And the lab tests are, we go in for the visit with Dr. Yi and with Stephanie and said, gee, everything looks good. We'll just keep on going. And,
Great. It's a great
and
story.
unfortunately, the neuropathy is still there.
I know I've heard from many patients. It's such a big, it really affects your life to have that. And it's just so important to really, I mean, back when you were taking Thalamin, you really didn't have anything else that you could take, but just, paying attention to those symptoms and maybe doing like a dose reduction or switching off of therapy can be really important. And I do think that the subcutaneous version can provide less of that. But, nowadays people don't have to worry about taking Thalamin anymore, at least not in the US. So that's a good thing.
Yeah.
Okay, so Dr. Yi, in our recent webinar, we discussed all the options available for patients who've relapsed from 1 to 3 prior lines of therapy, which includes many classes of drugs, such as immunomodulatory drugs, proteasome inhibitors, monoclonal antibodies, with most of the newer agents like CAR T cells and antibody drug conjugates reserved for relapse after 4 or more lines of therapy. So with all of these options, can you walk us through how doctors decide on a treatment regimen to give a patient at early relapse and what a patient should tell their doctor during this decision-making process?
Right. Yeah. So I think the decision, the choice of therapy at time of relapse can be pretty complicated, because I think for initial therapy, there may not be as much heterogeneity from the choice of initial therapy.
Yeah.
Because now we're moving towards 4 drug regimens, but at time of relapse, there can be a lot of heterogeneity, and I think that reflects the variability in terms of how patients, in terms of what the relapse looks like, in terms of, is it something that's a very gradual? Because I have to think about, when I think about a patient who's relapsing initially, I think about like what's the context. So if a patient is on lenalidomide maintenance, they're generally feeling pretty okay. They're back to their routine after dealing with all the drama of the initial diagnosis and their therapy. And then when if they were to have a relapse, is it a biochem? Is it the doctor telling the patient, or Stephanie, the nurse practitioner, telling the patient, oh, that you have a relapse, or is it the patient telling the doctor, or Stephanie, they're like that they feel like something's going on? So there's really that the patient have symptoms or not, because in terms of the relapse therapy, I kind of try to figure out like what's, and then they think about how do we maximize the patient's quality of life. Quality of life is important as well as quantity. Like quality of life and living longer and living better. And some of the choices in the relapse therapy can be pretty intensive. And sometimes I wonder, if a patient has purely a biochemical relapse and is asymptomatic, do you really need to do a therapy that is really intensive and involved versus something that, has similar benefit, but it might be more user friendly for the patient in terms of think about the quality of life part of it. So those are things I think about in terms of, so that's why it can be a lot of variability. So I think there are some patients where if it's purely just a biochemical or gradual biochemical relapse, say they're 4 or 5 years out. Now there are some patients where, and by then they've been on lenalidomide for a long time, and some patients do have loose stools, and they have other problems that emerge with lenalidomide being on it for a long time. Sometimes I do use just daratumumab as a thing for some select patients, but for patients where it's a more of a biochemical relapse, not a. But I feel like maybe they should do something more than just daratumumab as the same way. Then I do think about daratumumab pomalidomide index, methicillin, and then for the patients, who have, there's more substance to the relapse, or the patient has a clinical relapse, where if a patient has a new bone lesion, like it's like when John mentioned he has this rib issue, and then he has this new lesion, a soft tissue lesion. Maybe you would reach for something that has more, that may have more efficacy.
Right.
So that's where I think about the carfilzomib option. So I think
Mhm.
doing a CD30 antibody with the carfilzomib may be more appropriate. Sometimes, but carfilzomib can be a little bit more work on the patient as well because it's an infusion, and
Mhm.
it may not be right for every patient. So again, you have to individualize that
Mhm.
too. And sometimes, if they don't have significant peripheral neuropathy, sometimes a proteasome inhibitor like bortezomib, or Velcade, which they haven't had in a while, that might be appropriate too to combine with a CD3 antibody.
Mhm.
Now, when they go after that, you think about, and then we'll see how things go. Some patients, there are definitely patients they have where their treatment for their relapse lasts longer than the therapy they had for their initial relapse. That definitely happens. But for that, then you think about drugs which they haven't had before. Sometimes you think about using the cyclophosphamide. Sometimes you think about using selinexor, which is another option too, which is approved in earlier lines as well. Sometimes in combination. Again, you have to think about what drugs that people have had, and then also you can see it depends on the time frame when they were diagnosed, right? So John has had thalidomide like years ago, and you can see the pace of the drugs he's had. Whereas, I think that, so you think about cyclophosphamide and so, and then after you, and always think about clinical trials as well, because sometimes, and I do appreciate that a lot of people, to get access to a clinical trial does involve a lot of work, right? You have to go to a center that could be hours away. So that's something you do have to think about. Is it worth the drive to do that? And some patients, the clinical trial is the best way to treat. So I think for the earlier lines of relapse, the 1 to 3 relapse, if you have relapse 1 to 3 problems, we think about some of these newer therapies that we're evaluating in early lines. So the CAR T therapy or the bispecific antibodies or antibody drug conjugate, those are all being looked at earlier times. So, is it theoretically possible that, the CAR T therapy or something targeting BCMA, that could have the potential to be even better than what the patient had in the very beginning. So that's also super exciting.
Yeah. Agreed. That's great. So, Stephanie, what about patients who have comorbidities, right? So there's, often patients, they're diagnosed with myeloma, but that's not the only health problem that they have. Maybe they have diabetes, they have kidney problems. So having those comorbidities, does that affect their treatment options and sort of limit their treatment options at times?
Yeah, Andrew did a great job of kind of outlining from the disease perspective how we're thinking about things, but then and how complex that can be in itself. But then when you flip the coin and also think about from the patient perspective, how they're presenting and their life outside of myeloma and how that might affect treatment decisions, it can be even more complex. So diabetes in particular, which you named, with dexamethasone as really the backbone of almost all of our treatment regimens, that the dexamethasone as a steroid can increase glucose levels really out of control for patients and make that not even able to give it. Oftentimes we can reach out and work closely with endocrinology to get some numbers down and treatment together to make the dexamethasone happen, but there are patients that just can't tolerate it. Another thing with diabetics, some people come in with that peripheral neuropathy or that numbness or tingling in the fingers or toes, and then to try to add Velcade on top of that or add some of these regimens that we know might make that already existing issues worse. People who come in with mobility issues or even obesity, that can make mobility tough, and we don't want to add peripheral neuropathy to that. Kidney issues are also really common with myeloma and kind of can be part of the disease process there. And a lot of times we're able to manage that with dose reductions or switching out one treatment or one drug for another. But that can be something we have to monitor really closely and might at some point in terms of clinical trials might be something that excludes someone from a clinical trial at some point. I also think about like cardiac issues, especially with the carfilzomib, things that we have to monitor closely for: high blood pressure, heart failure. And one thing to think about is, because people are living so long with this disease, these aren't always issues that a patient presented with 10 years ago. It
Right.
might be that, a secondary cancer, not a secondary, but a different unrelated cancer develops in that time, or people, orthopedic problem develops in that time, other issues. And so sometimes something that you really didn't have to factor in earlier on, you get 5-10 years out, and it's almost a whole different health history now to make those treatment decisions. So again, something that you just continue to build that individualized plan for the patient.
Sure. Myeloma is nothing if not complicated, right? Very complex.
Yeah.
So speaking of clinical trials, John, did you ever think about going on a clinical trial at any point through your disease course? And what did your spouse or whoever, your caregiver, whoever, did you feel it was important or helpful? What did they do at the time of your relapse that was really helpful to you?
I didn't really consider clinical trials as long as there was a sort of a baseline treatment.
Right.
The next treatment came along. Though Dr. Yee, at my third relapse, he did show me one of the clinical trials that he was working on. So this was like almost 4 years ago. But that's when we instead decided to go with the DARA triplet therapy, and as Dr. Yee explained, it takes a lot more time. There's a lot more travel, tests, and so forth. So that was it.
Yeah. So, I mean, that makes sense. These are all things that need to be discussed together with your family and with your care team to really figure out what the best option is for you. So that makes perfect sense.
Yeah.
So.
In terms of, certainly my wife was my key support in the family and friends and so forth. So yeah.
So, Dr. Yee, should patients be asking about whether they're eligible for a clinical trial, even when they're especially, or maybe even if they have an early relapse?
No, I think it's always appropriate, because we do have clinical trials across all different stages of their disease process. So I think it's always worth asking if the clinical trial is appropriate. But as John mentioned, clinical trial does, it's not again, it's about individualizing to the patient's situation. And in some cases, the clinical trial is the best option, but in other cases, the clinical trial can be a lot of work for patients. So certainly, if John participated in a clinical trial, Stephanie wouldn't be part of his care anymore, right? He'd have to because we have to do everything in Boston, because it turns out, John sees us in Danvers, which is great. It's close. It's super convenient for John in terms of minimizing travel, parking, et cetera. And a clinical trial, does require more investment in time, energy, more visits. So I definitely appreciate that. But at the same time, clinical trials are great because, you're definitely patient for patients. They feel more empowered in their care, and they're contributing to understand the disease. And they also have a dedicated team of nurses and research coordinators that are dedicated to making sure that the trial goes as well as possible. It's almost like having a concierge service in a way, even though that may not be the best. But
I guess you could think of it that way.
But again, I also do appreciate that, for clinical trial, for patients, I read people go on vacations, and maybe some patients spend their winters in Florida. And the clinical trial does require that time commitment that you have to, be in the area for the treatment. So again, it really depends on where the patient is in their journey and what works for them. So I definitely encourage patients to participate in trials when it works for them, because I'm really interested in trials too. But I also realize it's a two-way. We all have to work together. So I don't want to make it a huge. We want to make sure patients have a positive experience in whatever they're doing.
Right. Yes, makes sense. Okay, so we are really almost at the top of the hour here. So we're just going to get some concluding thoughts from everyone. So, and I'll let everybody answer in their turn. So my final question for all of you is, what can patients or their caregivers do to prepare themselves for the inevitability of relapse? So John, I'm going to let you answer first.
Okay. I've always, discussed these things with Dr. Yee and Stephanie, with recognition, how long is this going to last? How long am I going to have a good response? And, what are the potential options? Talk with the doctor about the potential options for the next round of treatment. And, that's the main thing, have a good outlook. My responses have already been very good when we've had to change. So,
Yeah.
I've been very fortunate.
Yes. And I think that if nothing else comes through to patients from these Facebook Live sessions that we've been having with doctors, with care teams and their patients, is that it's so important to have a really good relationship with the care teams. And just that decisions are made in a sort of a collective manner. Everybody sort of considers all of the options and then in the end does what is best for the patient. It's so incredibly important. So Stephanie, what can you tell us about how to prepare for relapse?
One of my biggest kind of advice here is to keep coming to your appointments and keep those conversations going. I think a lot of people, feel that weight of the relapse like on them. What do I report? What do I say? And kind of thinking about it. And when you're coming to your appointments routinely, we can take some of that weight off. Like it's our responsibility to be monitoring your labs and to be asking you what's going on. And then we can kind of make those decisions together. And it's important to have as much support as you can outside of us as well. Sometimes that people have maybe a bigger support network than others, but hopefully we can even connect with, psychology or counseling, just even for managing and those coping skills, that this is just hard. And if we can kind of do this together as a team, and then maybe even connect you kind of outside of our team to more resources, I'm hoping that can be, as helpful as possible.
Yeah, that makes sense. Okay, Dr. Yee, you will have the final word.
Oh my goodness. Well, thanks again, Mary. And I wish I could say patients would never relapse, but in reality, relapse, is part of, it's part of the nature of multiple myeloma. But I think at the end of the day, I'm the overall message I want to convey is that is a positive message where while relapses can occur, that treatment options we have are just increasing, more effective, better tolerated, so that with the patients, when the relapse does occur, if it does occur, what's available could even be better than what you already were on before. So it's even possible that the next treatment could even be better than what you had before. Yeah. So I think that while relapses are part of the business, I think the options they have for treating are getting better and better, and that's why I think I'm glad MMRF is trying to encourage patient education is really key, so patients understand, so they feel comfortable in thinking about the next steps ahead. So this is a great.
Right. So, and one of the things that we really try to emphasize so strongly is communication between the patient and their care team is just really key. And, you guys are just such a great example of just like a group of people who really know how to communicate and are really, working together for, the benefit of the patient and making decisions together, which is, so vitally important, I think, for the well-being of the patient. So, I congratulate you on that. And we've had just some great conversations in this Facebook Live series between care teams and patients that have just been so demonstrative of how great that is when it works out together. And it often does. So thank you so much for being with us here today. On behalf of the MMRF, I'd like to thank Dr. Yee and Stephanie Sanford and also John Selin for joining us today. I'd like to thank everyone for taking time out of their busy days to watch this. And finally, I'd like to thank our sponsors, Adaptive Biotechnologies, Bristol Myers Squibb, Genentech, GSK, Janssen, Carrier Farm, and Takeda for their support of this session. If you have additional questions about what you heard today, please don't hesitate to call our oncology specialists at our Patient Navigation Center. Their number is 1-888-841-6673. Again, thanks to all our panelists and thanks to our audience. And we'll see you next time.
Thank you.